Thank you, Dr. Dinesh. I'll be talking about fluorescein angiography in age-related macular degeneration and other macular disorders. Uh, ARMD in old age, you have two friends. One is reading book and second is watching television. And patients who get affected with age-related macular degeneration has defect in central visual acuity. So AMD decreases all aspects of patient's quality of life, including the patient's ability to drive independently. So AMD needs to be diagnosed as early as possible with fluorescein angiography and OCT. Coming to the epidemiology of age-related macular degeneration, as a population is growing old, it's the major cause of concern in United States. 10% of the population above the age of 65 to 74 and 25% of the population older than 74 years is affected by age-related macular degeneration. Out of this, 10 to 20% of the patients are of exudative AMD, what we call as in wet age-related macular degeneration. So as our population is growing older and older, this number is going to increase and we have to diagnose these patients and treat it. Age-related macular degeneration is basically classified into dry AMD, wet age-related macular degeneration. Wet is described into classic CNV, occult CNV. There are variants of CNVM that we call as an IPCV, RAP lesions. Then there are certain lesions which mimic like age-related macular degeneration, that is IMT and adult onset vitiliform dystrophy. So in this talk, I'll be talking about fluorescein angiography features of all these diseases. Coming to the dry macular degeneration, the hard exudate is basically tiny, round, discrete, with distinct margins. Large drusen's are more than 63 microns in size. Soft drusen's have indistinct margins and tend to be large. Then we have, if multiple soft drusen coalesce, we call it as a confluent soft drusens, and due to merging of soft drusens, it can later mimic as calcified drusens and mimic as atrophic patches in retina. Then we have a drusenoid RPED when multiple soft drusens coalesce together and extend more than 500 microns. We call this as a drusenoid RPED. Dry RMD accounts for 90% of the patient of age-related macular degeneration. It has little impact on vision unless significant RP atrophy develops. If you see here these yellow things, what you see here is a drusen. I think everybody knows how to diagnose it. The typical feature of fluorescein angiographic feature of drusens are you will see staining. Both staining and leak are hyperfluorescent things, but the important thing is how to distinguish between staining and leak. So if you have to have an early photograph and you have to have a late photograph. If you compare early to the late photograph, the margins of these lesions will remain same from early to late photograph, and that's why we say these patients, there is a staining. If these lesions leak, then we say it's an active hyperfluorescence where it depicts classical CNVM, that is choroidal neovascular membrane. If we see the OCT or drusens will mimic as RP undulations, and these are autofluorescent pictures of geographical atrophy, which is best diagnosed on autofluorescence. If you do fluorescein angiography, this will depict as white lesions, hyperfluorescent lesions with well-defined margin till the late phase. But the progression of this disease is best managed or followed by autofluorescence, and you can see this hypofluorescent area. These are areas of geographical atrophy. Coming to the CNVM, in macular photocoagulation study, we have classified CNV into subfoveal, juxtafoveal, and extrafoveal lesions. But in the VEGF era, subfoveal and juxtafoveal need not to get differentiated. Only what we need to recognize is an extrafoveal lesion, because the treatment modality is extremely different. In extrafoveal lesion, you can go ahead and treat these patients with focal laser. Like you can see here a yellowish white lesion, and you can see a subretinal hemorrhage. On fluorescein angiography, you can see a classical lacy pattern of filling in early phase, which leaks in the late phase, telling us, yes, it's in wet AMD within CNVM. Since it's away from the macula, we classify this CNV as an extrafoveal lesion, and you can do an focal laser. And if you can do focal laser in these kind of patients, these patients will not require any VEGF inhibition over a period of time. And this is another patient of CNVM. You can see lacy filling just touching the fovea. This is a classical example of juxtafoveal choroidal neovascular membrane. Another patient, since it's involving the central of the fovea, you can see here a subfoveal CNVM. The important thing here is you can see this block fluorescence area here. You have to trace these vessels. You can see the vessels are traveling over this area of block fluorescence. If the vessels are over the block fluorescence, that means the hemorrhage is in the subretinal area. So the lesion is subretinal, and the most likely lesion in subretinal area is wet AMD or age-related macular degeneration. Coming to the occult CNV, it's basically occult CNVM, what we call as an RPED. It can be in fibrous RPD or it can be in plain serous RPED. On fluorescein angiography, you will see a pooling of the dye which increases in the late phase. It's very difficult on fluorescein angiography to distinguish between an serous pigment epithelial detachment and a fibrovascular PED. The only point what you have to remember in this is if you have a notch like this, then it's an fibrovascular PED. The diagnosis is best made on OCT, or you might have to do an ICG angiography to diagnose these cases. Like in this case, you can see on the right you have a fluorescein angiography picture, on the left you have an ICG pictures. On fluorescein angiography, you can see in late phase there is a mild leakage. You don't get much of information on fluorescein angiography, but the moment you do an ICG angiography, you can see a block fluorescence here and there is a hot spot here. So most probably there is an fibrous element in this PED at the tip of the PED, and there is also a notching here. So meaning thereby if you have a notch and a hot spot, this is a fibrovascular PED, and these patients we diagnose as in wet age-related macular degeneration and will require an VEGF inhibition. Coming to the subset of disease, what we call as in PCV or polypoidal choroidal vasculopathy, it usually presents with large subretinal hemorrhage with exudation. The diagnosis is confirmed with ICG. PCV was first described as entity predominantly seen in Asian population and black females, and usually its area of presentation is peripapillary region. Current expansion of clinical entity recognizes PCV as prevalent also at the macula in elderly people, irrespective of race and gender. It presents between the age of 50 to 65, mainly in African American, that is the black population, and its incidence increases in Asian population and especially in South Asian population. The incidence in the South Asian population is somewhere around 10 to 15% of age-related macular degeneration presenting as CNV. It's characterized by dilated choroidal vascular channels ending in orange bulbing polyp-like dilatation in peripapillary and macular area. Clinical features are large subretinal hemorrhage, exudative neurosensory detachment, recurrent hemorrhagic PED, and vitreous hemorrhage. It's usually bilateral symmetrical. Here is an example. You can see this orangish lesion. These are typical of PCV with lot of exudation. If you do a fluorescein angiography, you will see a diffuse hyperfluorescence which leaks in the late phase. But ICG is typical. You can see a polyps here. Another patient, a very typical presentation with PCV, you can see multiple areas of polyps here in the right eye, and you can see in the peripapillary region, these are polyps, and there is a large PED. So the diagnosis of PCV is made. These patients does not respond to plain VEGF therapy. These patients require a combination therapy, that is PDT with VEGF inhibition. Coming to the next lesion, which accounts for around 10 to 20% of wet AMD patient is RAP lesions, or what we call as an retinal angiomatosis proliferans. What we were looking till now was the lesions which were of choroidal origin. RAP is basically has an intraretinal origin. It usually presents bilaterally, and you can see a lot of exudation with intraretinal, small intraretinal hemorrhages. It starts in the intraretinal layer, that is stage 1. It goes to the retinal pigment epithelium, and in stage 3, it creates an pigment epithelial detachment. Again, the diagnosis of RAP is more made on ICG rather on fluorescein angiography. On ICG, if you see, you can see a hot spot here depicting that these are intraretinal lesions, and these needs combination therapy. There are multiple lesions which we confuse with age-related macular degeneration, and one of the lesions is idiopathic juxtafoveal telangiectasia. IMT is basically the defect in the neural layers of the retina. There's no neovascularization. Clinically, you can see a grayish white area of discoloration temporal to the fovea. On fluorescein angiography, on early phase, you will see areas of capillary non-perfusion, which leaks in the later phase. So with this picture, you don't need to get confused with CNVM. These are lesions of IJT, and you don't need to do anything in these kind of patients. It can be classified into group 1A, group 1B, group 2 and 3. What we see is group 2 and group 3. Here is another example of IJT, or idiopathic juxtafoveal telangiectasia. You can see grayish lesion temporal to the fovea. On fluorescein angiography, what you see leaks in the late phase. Coming to the next disease, this is adult Whittley-form dystrophy. This usually presents between the age of above the age of 55, and this yellowish lesions occurs because of the disintegration of the photoreceptors. On fluorescein angiography, it usually gives an appearance of a block fluorescence. This is a patient, the same patient we did an OCT. You can see there is a thickening at the layer of RPE, and there is a slight amount of fluid. We gave intravitreal Avastin in this patient. Patient didn't respond. We gave a second intravitreal Avastin in this patient. Patient didn't respond. Then we said why the patient is not responding, we should revisit our diagnosis. We did a autofluorescence in this patient, and you can see this autofluorescence fluorescent area telling us what we were treating was a adult onset Whittley-form dystrophy. So you need to distinguish these lesions from CNV and age-related macular degeneration, because these lesions does not require any treatment. Autofluorescence is imaging provides information about RPE. It's especially important in macular dystrophies, helps in documenting and the progression in geographical atrophy. So to conclude, AMD is a major health problem. Early diagnosis with FFA and OCT are key to restoring good vision. ICG and FAF should be done to distinguish between variants of age-related macular degeneration. Thank you very much for your kind attention. Any questions, please?